Yeah, welcome to this delightful evening. Today marks the auspicious beginning of our ISAR Fertility Catalyst webinar series. It is truly pleasure to witness the gathering of India's top-notch IVF and gynec experts on this platform. Each one of you are the catalyst, I can say means catalyst in the field of IVF and gynae, were the contributing significantly innovative medical treatment across the nation. Once again, I welcome you, and we at UNS we pride ourselves as one of the fastest growing nutraceutical company, which is dedicated to making the major difference in lives of people by offering best class nutraceutical products. Our infertility portfolio includes brands such as CoQ 300, CoQ Man, CoQ Fem, CoQ LC, and CoQ Ford, which helps patients to empower their parenthood dreams. With this, I would like to invite our medical head, Dr. Manish Garg, and to introduce our conveners and set the context of today's proceeding. Over to you, Dr. Manish Garg.
Sure. Thanks a lot, Nakul. Hope my slide is visible.
Yes.
The laser pointer. So at the outset, I would like to express our sincere thanks and regards to Dr. Amit Patki sir and to entire team of chairs, the speakers, as well as the experts who are there in this meeting, and obviously to all the audience to help us make this monthly webinar a big success moving ahead. So I'm Dr. Manish, part of the medical and regulatory team at Universal NutriScience. What I'll do is, as Nakul has already highlighted, we are one of the leading nutraceutical company, and that's all with all the blessings from Dr. Amit Patki sir and all the star of galaxy of speakers and experts who are there, and obviously all the healthcare practitioners across India. So I'll just take a brief to introduce about Dr. Anu Agarwal, who's the convener for this meeting. She hails from Varanasi, the Kashi, the Banaras, the holy city within India, where everyone is striving to fly to or to go to and get access and all the blessings. So she is a OBSEM Gynex, and she is also a executive committee member of ISAR. She is the director of the Vanch Fertility and Test Tube Baby Center, and also part of the Ayushman Hospital and the multi-specialty hospital. She is joint secretary Vox. Her field of interest is more into minimal invasive and ART, and has done a lot of scientific and academic work, whether it's presentations, publications, and research work. So with this, I pass it over to Dr. Anu Agarwal and request her to take over the proceeding, ma'am. Over to you, ma'am.
Thank you. Thank you, Dr. Manish, for this wonderful introduction. Very good evening, everybody. It is my proud privilege to welcome you all on behalf of ISAR on this very first series of ISAR Fertility Catalyst. I would like to acknowledge Central Team ISAR, our Honorable President, Dr. Amit Patki, our Secretary General, Dr. Asha Bakshi, our Vice President, Dr. Sunita Tindulwalkar and Sujata Kar, for bestowing me with this wonderful opportunity to interact with you all. Unfortunately, my co-convener, Dr. Festy Lewis, he couldn't join because of some personal reason. So to start with our session, first of all, I would like to invite our today's chief guest, our dynamic president ISAR, Dr. Amit Patki, to say a few words. Welcome, sir.
Thank you very much, Anu, and congratulations to you and Dr. Fessi for having initiated this wonderful concept of ISAR Fertility Catalyst. And I'm sure looking at your first program, it is going to stimulate brains of all the listeners along with me because of the topics that you have chosen, and more importantly, the wonderful speakers that you have chosen for this webinar. I would also like to thank Universal NutriSciences for coming up so forthcoming to be with us in this webinar to promote education. I know there are a large number of webinars which are happening presently, but this is a unique webinar because it looks at trending topics and topics which are of more practical need for the listeners. Let me thank all the speakers, Dr. Santosh Gupta, along with the chairs Anshu Jindal, Tarini Taneja, Manju Dagar, the speaker, Dr. Rita Bakshi, along with her chair, Dr. Neelam Ori, Dr. Kanchan Sharma, Dr. Sunita Arora, and the panel moderator, Dr. Sujata Kar, along with the panelists, Dr. Shaheen Anjum, Dr. Neelam Mishra, Dr. Varda Arora, Dr. Anchal Garg, Dr. Sonali Gupta, Dr. Namrata Ori, and Dr. Parinika Agarwal. I think, Anu, you have done a fantastic job by getting all these stalwarts on one platform. And I once again congratulate you and Jesse. Fessy, I know Fessy is unavailable today, but I'm sure you are capable of doing this all on your own. So best wishes to this webinar. And I'm sure this webinar will become a hot topic for people to join every month. They will look forward to it. And I'm sure you will increase the popularity of this Catalyst webinar. So thank you once again to the conveners and to our Universal NutriScience for collaborating with ISAR on one yet another program of us. Thank you so much.
Thank you, sir, for showing this confidence. And definitely I'll do my best. Thank you, sir. Now I would like to invite today's guest of honor, our Secretary General, Dr. Asha Bakshi, Madam, to say a few words.
Thank you very much, Anu, for inviting me. And it's really always a pleasure to hear the enthusiastic address from Dr. Amit Patki, our able president, under whose presidentship ISAR is doing very well, and the membership is also growing up. And today we have more than 6,000 members, and it's really heartening to know that. And it's a very good initiative taken by you and Dr. Fessy Lewis, the Catalyst series. And I think the name itself is so vibrant that I'm sure this series is going to go very well. And today you have taken a very focused topic, and this is a topic, the diminished ovarian reserve. It is, I think, we all are interested to know anything that is possible about diminished ovarian reserve, because we all are fed up with all these patients who come with a young girl coming looking so smart and so same trim, smart, and then when you have a look at the ovary, then you're aghast. You feel so sad that, oh my God, such a young girl having only 1 to 2 antral follicles, and that's really very sad. So I'm sure we will have lots of learning points today by Dr. Rita Bakshi, who is going to talk to us about dual stimulation in poor responders, and the chairs, Dr. Neelam Ori, Dr. Kanchan Sharma, and Dr. Sunita Sharma. And it would be again nice to hear about this poor responders in low-cost IVF settings. I think that's a very, very interesting topic, because this is what everyone would like to know about, that, because cost is again a very important factor in our country. And Dr. Santosh Gupta, whom I met only a few days ago, I'm sure she's going to do justice. And it would be nice that to listen to Dr. Anshu Jindal, Dr. Tarini, and Manju Daga as chair, and then our vibrant and most intelligent Vice President, Dr. Sujata Kar. She is going to moderate a panel, and the panelists are Shaheen, Dr. Neelam, Dr. Varda, Dr. Anchal, Dr. Sonali Gupta, Dr. Namrata, and Dr. Agarwal. So I'm sure this panel discussion is going to be very, very interactive, and we'll really learn a lot. So, and I'm sure every month you are going to bring very interesting, focused and crisp topics which are very close to our hearts, and then the series gets really popular and people look forward to it, like how our Soliloquy series is going on. Similarly, this series will go on. So all the best, Anu. And one request is there that we have got a very good youth brigade in ISAR. Almost 42 members are there in that youth brigade. So you can involve those people also. And the list you'll get from ISAR office. And you can involve those people also wherever. So that will be a help. And I think it's very important to involve all the ISAR members as much as possible, like you have come up. And I can see a good leadership in you. So that's how we'll develop more and more leaders in ISAR. So that is what is the demand of time. So nice seeing you, nice listening to you, and I'm looking forward to this series. Thank you.
Thank you, ma'am. And your point is well noted. I'll take care. Thanks a lot, ma'am. So now we're going to start our webinar. And as an ART consultant, we all want to give our patients their own genetic baby. And it is challenging for all of us to stimulate these patients, these poor responders patients. So our first topic is poor responders in low-cost IVF setting. For this, I would like to invite our chairpersons, Dr. Anshu Jindal. She is consultant IVF specialist, obstetrician and gynecologist, Jindal Hospital and Fertility Center, Meerut. She is joint treasurer, UP ISAR, editor, UP IAGE, member in Fertility Committee, FOXY. She has won the gold medal for best postgraduate, LHMC New Delhi, 30 awards from different organizations, trained in laparoscopy at University of Kiel, runs a FOXY accredited center of excellence for laparoscopy and infertility training. And she has many publications and presentations. She has written chapters in 8 textbooks of fertility, over 65 national and international presentations. Her special achievements are appeared on the front page of Times of India.
We can keep it short, or no, we can keep it short.
Okay, sure, ma'am. So
Thank you for
we
the
all
lovely
know you, ma'am,
introduction.
very well.
Thank you.
Our next chairperson is Dr. Tarni Taneja. She's chairperson, Delhi State Chapter ISPAC, Vice President, Delhi IMA. And she has been awarded as Bharat Gaurav Samman Awards. And she has received FOXY President Late Kuti Lifetime Achievement and FOXY Legend of Gynecology and APJ Abdul Kalam Excellence Award DGF. Welcome you, ma'am. Our third chairperson is Dr. Manju Tagar. She's a friend of mine. We did a SARship at DDU College together. She's director, Nestling Gynecology and Fertility Center, ex-head of department, Pratiksha Fertility and IVF Center. She's ISRA certified reproductive endoscopic surgeon. And she's trained in advanced embryology from NU Singapore. And she's a life member of IFS ISAR and various other organizations. Welcome, Dr. Manju. I would request Dr. Anshu Jindal to introduce our speaker, Dr. Santosh Gupta.
Yeah. Dr. Santosh Gupta is going to talk on a very interesting and a very relevant topic, and that is poor responders and how to stimulate them in low resource settings. Dr. Santosh Gupta is a senior consultant reproductive medicine at Nova IVF, Bangalore. She has a teaching and training of various postgraduate fellows under her. Her present affiliations are she's an executive committee member of BSOG, Joint Secretary of Karnataka Society of Assisted Reproduction, and she is an MS from Jaipur, elected member of the Executive Committee of KISAR and life member of KISAR. She has various awards and recognitions to her credit. And today, ma'am, we're very eager to hear from you what you have to say on poor responders and how we can stimulate them, especially in low resource settings, which is very relevant to our country, because sometimes so many of our patients cannot afford all the hi-fi treatment. They cannot, sometimes we don't even give them recombinant for that reason because they can't afford it. So it's very relevant whether we should combine it with letrozole or whether we should combine it with clomiphene, our stimulation protocols. What are the latest trends? We would like to know from you. So welcome on this podium, and I congratulate Dr. Anu for such a nice endeavor and involving me in this wonderful endeavor. So over to you, Dr. Santosh.
Event manager, can you just unmute Madam Santosh Gupta?
Actually, event manager already sent a request to Dr. Santosh Gupta.
Ma'am is here.
Yeah, she is joined.
Yeah. क्या हो रहा है? Hello.
Just give us a minute. We are just trying to sort out the technical challenge at Madam's end.
So in the
Dr.
meantime, I
Vikas,
think we can
please call to
discuss
Dr.
about
Santosh Gupta.
Hmm.
Dr. Vikas,
about
are you
poor
there?
responders. How often do we encounter poor responders in our clinical practice? I think almost we are now finding young poor responders, as Dr. Bakshi also said, that it is so disheartening to see a patient who's so young looking, slim looking, and then you find her ovarian reserves have gone down so, horribly down. And these become a big challenge for us. How to treat them. And I think this topic is going to highlight some of the very important features, combining it with to make the protocol more, patient friendly as well as economical to the patient. Sometimes we combine letrozole or we start with clomiphene citrate and then start on with gonadotrophins. And so I think we'll be discussing more of this in detail now.
Yes. Madam, I want to stress on one point. These nowadays, these environmental disruptive chemicals,
Yeah.
they're endocrine disruptive chemicals, they are
So rampant.
quite responsible for these poor
Hmm.
ovarian reserve. These
Hmm.
phthalates and these plastic products, pesticides, they all play a role in this. Because
But I don't know
nowadays we are
how
more
much
and
they
more cases.
contribute, but what degree to which they contribute, we don't know. But yes, we are seeing a lot of poor responders who are young. So definitely they have a role, but how much of the contribution these disruptors are doing, that is very difficult to,
Dr. Gupta, ma'am, do you want to share your slides and RX event? Can you unmute, ma'am?
What happened?
RX even already sent the request to Dr. Santosh Gupta. So,
She is rejoining. Dr. Santosh is rejoining.
What happened?
I think in the meantime, we can ask Dr. Rita Bakshi how she treats her young poor responders, since we have some time. Dr. Rita.
Thank you, Anshu. Nice meeting everybody here. And see, I think I agree with you 100% that AMH and your
Antral follicle
follicle
count.
resource is really depleting very, very fast. You won't believe. In fact, to the level that even the 28, 29-year-olds are having an AMH as low as 1.9. And it's really surprising. Because and I think that's where egg freezing has taken such a large jump, because there's no other way of people who, with such a depleting reserves. Now, what could be the reason? I mean, even sperm levels are going low, but obviously they have an edge. But really, I don't know. I think somewhere the food and the pesticides, I think, because there was a time when we used to have kida in every sabzi that we used to eat, whether it was bengan or now you never see them, because they have genetically modified seeds with pesticides. So we are eating poison. We are eating poison. That's why cancer and all these things, I think, are rampantly increasing. Well, what do we do? And I will share with I have found that when I'm doing oral ovulation cycle, or whether I am doing a nice gonal-F menopause cycle, the results have not been very different. So I have now really switched on to an IVF light program with much more of ovulogens, plus of course
Gonadotropins.
maturing of gonadotropins here and there. But really speaking, I think that's where I have found my.
And do you prefer an antagonist cycle or you prefer an agonist cycle?
I am a very, very strong propagator of antagonist cycles, so I'm very happy. Although in very, very low response and in PCOS, both, an agonist cycle works equally well.
Yeah.
Ma'am,
But,
sorry to interrupt.
Yes.
Ma'am, Dr. Santosh is having some technical issues. So, ma'am, can you start your lecture?
Why not? I'll be happy to do that.
So, Dr. Rita will start your lecture. Ma'am's topic is how useful is dual stimulation in poor responders. So for this, I think Dr. Anshu can introduce Dr. Rita Bakshi.
So Dr. Rita Bakshi is known to all of us, a very good friend of ours. She's MBBS from Lady Hardinge Medical College. And actually, I know her from those days. DGO from Stephen's Hospital, MD Gynae. And she's a through and through a Delhiite. And she's also done a diploma in ART from Singapore, WHO fellowship in gynae oncology from AIMS, cosmetic gynae fellowship. I mean, the list is too long. She's a senior consultant in fertility specialist and endoscopic, a good endoscopist, as well as a cosmetic gynecologist. And she's a chairperson in the institutional committee for stem cell research. And the list is very long. She has so many awards to her function. She's a very dynamic person. And I'm really waiting to hear from her on this very interesting topic.
Thank you.
The stage is all yours, Dr. Bakshi.
Thank you. Thank you. Thank you, Dr. Anshu. Thank you so much. So let's go ahead with the topic. And that
And you want to make it full screen, ma'am?
I will do that. I don't know why it's not coming full screen.
Slideshow पे जाओ मैम. Go to
Trying
slideshow.
to make it into a slide share, but
मैडम एक बार स्टॉप शेयरिंग करके वापस शेयर कर दीजिए.
Okay.
that's okay.
That's okay. Yes, ma'am.
All right, thank you, thank you. So coming to the topic of double stimulation, as we were talking of. Now we know, as Dr. Anshu was also saying, nearly 9 to 25% people of the infertile women that we see are having poor response to controlled ovarian stimulation. And previously we were using the Bologna criteria, in which 2 of 3. So we were talking of age more than 40 years, a previous poor ovarian response, that means less than 3 oocytes in a conventional protocol, and an abnormal reserve test of AMH between 0.5 to 1.1. So if we had 2 factors, this was the criteria that we were taking for poor response to controlled ovarian stimulation. Then, of course, we shifted on to the Poseidon classification, and this is, patient-oriented strategies. This is individualized oocyte number. So we also looked at women less than 35, in group 1 and group 2, which are women, in which you don't expect a poor response because their AFC is more than 5, their AMH is more than 1.2, whether they are less than 35 or in group 2 more than 35. But this is a surprise element. So these are the ones you don't expect. But of course, group 3 and 4, which have a low cohort, their AFC is less than 5, their AMH is less than 1.2. So this is a group which again we'll have to see what to do and what can we do differently for the. So now we have a different approach, let us say, to both the groups 1 and 2 and 3 and 4. So I'll come straight to the protocol that I'm going to talk on, and that is the double stimulation in one cycle. We don't go to 2 cycles. We take 1 cycle and we stimulate twice in that same cycle. It was way back in 2003 when somebody suggested that luteal phase follicles are equally competent. And if I have to tell you, the other day I had a very educated patient walk into my OPD and she said, Madam, in India, you only do follicular phase stimulation. But the place where I am coming, she was coming from Europe, she said, I have been only doing luteal phase stimulation. They wait for me to ovulate and then they start stimulating me. So it was very different for me to hear that there are people who are gone only on luteal phase stimulation also. Well, this was a live birth in 2010, and originally, of course, all these different kind of stimulation were for fertility preservation, but now we know that we are not looking only at that. And why, what is the physiology behind? Previously, single recruitment, people believe single follicle, will get recruited, and this is how we used to only look at that. Slowly, we understood that there is a wave theory, there is a continuous recruitment, and you have not only one single wave, you have more waves. So you have more cohorts which will come up, and they can come at different stages of life, and they can be selected to develop. And how many, so around 68% women have 2 waves and 32% women have 3 waves. So you have more time in a same cycle to have more number of eggs that you can. Now, this is the, protocol we started from the second day of menses, FSH and LH, HMG, whatever was started. And on around day 10, trigger was given, ovum pickup was done. They left a gap. Okay, they left a gap. And then again, they started stimulating again gave a trigger, again took an ovum pickup. Now, we will be talking of 3 things. One, should the gap be there? What should be the gap? One. Second, what should be the trigger? Agonist, HCG. And third, what about the gonadotropin that we are using? So on the 3 fronts, on the dual stimulation protocol, we'll be talking on. So is there, and this is the most important question, is there an increase in the total number of N2s when you are doing a double uninterrupted? So I'm also going to give you trials, all the trials that have been done till now, and you will find that this is Brussels, Belgium, where they had this large, from 2 years, they did this trial of total 70 patients. They took women 25 to 40 and AMH around 1.5 and around 6 follicles, less than 5 oocytes retrieved. This was the, and the time they were really looking at only one thing, and that was total number of N2s. Of course, the secondary outcomes were fertilize, pregnancy, duration, gonadotropin, all that. But the main thing that they were looking at total number of N2 oocytes. So what did they do? Now, this was, of course, where they had a long-acting FSH, the choriofolitropin alpha. So in a conventional protocol, they gave on the second day, they gave the injection. After 7 days, they added a folitropin beta 2 to 5, and then they gave an HCG and did an oocyte. This was a normal conventional protocol. Then they took a group B in which they did the same thing, but they did not stop the gonadotropin even for a day. Okay, so this was a continuous gonadotropin, and this is where I'm talking of the gaps part. So they give the agonist, when the follicle they thought was ready, they gave an agonist trigger, they did the pickup, but the folitropin beta continued. Okay, the cycle was cancelled if after 13 days of recombinant FSH, there was no response. Otherwise, they continued. So, why I'm going to talk about all this is you will find that you can do the same thing in so many different ways, and everybody is trying differently, and yet the results are, whatever statistical analysis that will be seen. So this was what, and I will just come straight away to the results that you will see that, whether there was really speaking in this cycle, not too much of a significant response. There was no increase in the total number of N2 side when they were comparing one conventional to dual uninterrupted stimulation. So they also, in this study, they also came out that we should co-administer HCG also in low responders. So a dual trigger that we talk of, agonist plus HCG, and this is what they said. Now, our main discussion is, does it work in poor ovarian responders? And this is again as a Shanghai protocol, the protocol that I'm also very fond of, in which we start with clomiphene, starting from day 2, and letrozole together. So clomiphene, 25 milligram for 10 days, and letrozole 2.5 milligram for 5 days, and HMG if you require in between. And one or two or three injections of HMG, given agonist trigger, do an oocyte retrieval. Again, next day itself, we started again with letrozole and HMG, this time continuous HMG, again agonist trigger and oocyte retrieval. Well, in my case, we don't give so much of HMG, but well, I mean, this is what the study said. So if you see again in this study, whether the number of eggs and the pregnancies were, dual stimulation is viable and a potential option for poor ovarian response and oncophos. So in this study, you would see that the number of M2s that were retrieved were much more. Really speaking, they were double. And therefore, they said this is a viable and a potential option. Now, this is again a multi-center, 4 IVF centers from France were doing this study for about 2.5 years. And the primary again was the number of oocytes. So if you see again, the controlled ovarian stimulation, they gave a dual, and the Hubaldi 2016 is the one which gave the 5-day gap and then did this. Now, and this is where I want to bring your attention. Dr. Massin in 2023, he gave a gap HCG trigger in the first follicular phase and HCG trigger in the luteal phase also, and a gap of only 1 day after the ovum pickup. Left 1 day, started the gonadotropins again, gave an HCG trigger. So 2 HCG triggers, and this was it. And in as recent as 2024, this is a paper from Boudry et al., and in which he gave agonist in the first half and HCG trigger in the second half, and then they did this. So these are the kind of, I thought I'll put it in one slide, all the major studies that have been done on dual stimulation with the gap, with HCG, with agonists, with gonadotropin, and with oral ovulation all together. So, obviously, all of them have found a little difference in the results, which you will also see. And what is the real advantage that we get is something that so I will just come back straight to the results, not to, no benefit they found of dual stimulation over 2 conventional ovarian stimulations in terms of total and mature oocyte retrieval. So if you do 2 cycles spread over time, and or if you do 1 cycle continuously, they did not find any difference because the risk was of freezing and thawing because it's mandatory. So in all the random or dual stim, it is mandatory according to them of freezing the embryos, thawing, and so this is one extra step, and the only benefit is to shorten the time to a second retrieval. So now if you are short of time, as in fertility protection or people who don't want to wait, in them it is it's of advantage. Now, is it cost effective? Well, this is another thing that all of us are bothered on, and this is this was a European study in which they did a retrospective study to find out whether the whole thing turned out to be. So you will see the total cost per live birth was 87,000 euros corresponding to 49,000 euros wherever they were. So this is much above the limit suggested by NICE for cost effectiveness. So according to them, it was not cost effective either. So in the present study, the live birth rate was just 6%. So chance of success as below is, we need 16 women to be treated to get 1 live birth. Now coming to the next question, is dual stimulation better than conventional for POR? Because again, different studies will give you different results, and I thought again, this is a Chinese study, and you will see the, if you are doing a 2 consecutive mild stimulations compared to a double stimulation, so you'll see the amount of gonadotropin usage is so much lesser, and the results were nearly same. So there was not too much of a difference in the dual stim protocol is inferior to the 2 consecutive mild stimulation protocol in terms of the number of frozen embryos, and there's no difference in pregnancy outcome between the 2 protocols. Now, this is an Abu Dhabi study, coming from our UAE, and you can see that here they did find something significant. They said double stimulation results in more mature oocytes and saves time for patients of poor ovarian reserve who are willing for pregnancy or fertility preservation. So what about cycle cancellation in dual stimulation? We know we start stimulating in the second half, but do you really always get? So what is the amount of cycle cancellation? And this is the study that they showed was that dual stim increases the chance of achieving pregnancy by accumulating more eggs or more embryos. And this is something I think Dr. Sunkara has been saying. The moment you get more oocytes, our talk is only whether you do it in one cycle or you compare it with 2 cycles. So in total, 81% of patients had available embryos, and the cancellation rate really, people get tired, and I think time is of essence. So if you can finish the whole thing in one cycle with an equal amount of good result, is something probably which will be of advantage. Is there any influence of the starting day off? Now, what I said is the gap. Should you give a 1-day gap, 2-day gap, 3-day gap, 4-day gap, or no gap at all? So this is where they did the study, and the good part about that came out that number of oocytes retrieved did not differ depending on the stimulation. However, competent oocytes in terms of fertilized and blasted appeared to be lower when the second stimulation starts before the 4th day. So, normally in our, we give antagonists for 3 days and then start on the 4th day. So this is what they also found, that the competence of oocytes was better when you gave this gap. Is there any effect of different trigger drugs? This is what we were talking. Should we go agonist? Should we go dual? What is the kind of trigger? Now they have done HCG and urinary and recombinant. So they tried all 3, urinary, recombinant, and agonist, and you will see the use of agonist or recombinant HCG. So is a better drug than urinary in both FPS as well as luteal phase. So I think we are all now more or less using recombinant HCG or an agonist trigger, which is what they also found. So probably not use urinary. Now, is it better, again, is luteal phase better than follicular in dual stim protocol? And this is where the luteal phase stage results in more oocytes. And this is what I'm saying. So you keep finding different studies from big groups coming in, and this is where we are maturing. And this is again, which you can see what out. So, because the dropout rates in you give one cycle and then you ask them to come after 3 months, the dropout rate is so much higher. So this is where the luteal phase derived oocyte increase the clinical pregnancy rate in a single way, fulfilling what you want, and really avoiding dropout. Well, I think we'll nearly come to the end of, say, what is the rationale behind luteal phase stimulation? It's the high estrogen and progesterone levels, which result in more synchronous follicular development and promotes the proliferation of FSH receptors on the granular cells. And that agonist trigger has a small flare-up effect, which can improve the synchronization of the follicular development, which results in slight increase in the FSH, which promotes the growth of follicle with a diameter of 4 millimeter or less. Well, at the same time, elevated FSH is lower than the threshold that allows the periodic follicle recruitment, rendering follicles less than, unable to begin to develop. So this is where, our trigger part comes in, agonist, and how it helps. So can we do fresh? I'm just coming to the last few. Can we do fresh transfer? Well, there are people who have tried even this. So we can't say that we are finishing with this. They have they tried doing a fresh transfer, and in this study they found their results were comparable, although I am not sure how did it help. But what about the embryo quality? We talked of euploidy. We talked that They have done the genetic checking of the embryos, and it's similar euploid. So no more should we be scared of luteal phase stimulation, random start. This is what we are getting. Really speaking, this is what we are learning. Number of available euploid blasts increases, thus increasing the chance of pregnancy. So I will, I think coming to what are the strengths. Increased number of oocytes and embryos retrieved, more patients, more euploid blastocysts, and no difference in competence between follicular and luteal phase. Weakness is that more, there's no RCT on cost effective. We don't know. Freeze all, according to me, also is mandatory and applies only to advanced maternal age and decreased ovarian reserve patients. Opportunity is reduced time, as we said, better tolerated than consecutive cycle, theoretically reduced dropout rate, and may increase our knowledge regarding follicular and ovarian physiology. Threat is cost, increased total cost of gonadotropin, and we don't know the long-term effect on the biological, obstetrical, neonatal. So we will learn all this as we grow with time. So I'm just to give the last IFS was given, has just come out with the guidelines, and their question was, is it superior or too conventional, the DICE protocol, the same thing that we talked of. Recommendation, it is not recommended over the antagonist protocol in poor responders, and they said that evidence is strong. So the duo stim superior to antagonist or mild stimulation. So this is what they say. It is not recommended. So antagonist is what the preferred protocol. Now, rationale behind the recommendation was that compared to conventional stimulation, duo stim, again, same thing, more reducing dropouts, all that we already talked of, and data on cost effectiveness, we don't know how it does. So same thing, I think that, is fresh transfer, well, this is what we should research on, whether it is possible after dual stimulation to also do it. So obtaining more higher quality oocytes and embryos in a short period of time, shortening the pregnancy time. I think this is what we are looking at. And patients with malignant, advanced maternal decrease, these are the people that we already look at. Mandatory requirement of freeze all and lack of cost effectiveness data. So this is where I think I will put an end. Thank you. Thank you.
Yeah, thank you, Dr. Rita Bakshi, madam. This was excellent to hear from you. Of course, as we were saying that dual stimulation, many patients from the foreign country and the patients who are under the taking treatment of the cancer for the cancer patients, they have less time. In those very patients, we have a very good option of dual stimulation. My question is, in how many patients have you used this type? You have given very good study reports that we give can give 1 day or 1 to 3 days or even 5 days, and different studies I have seen. They were very good studies. What about your personal experience?
Yeah. So, to be truthful, poor ovarian reserve is of course one group where we use. I will tell you where I use. Sometimes, I'm stimulating and I find I should be looking at, say, 12 or 14 oocytes, and only 3 or 4 have come up. Rest all I can see are small. In those cases, if I do a dual stimulation in the same cycle, and that is where I have found, my confidence in luteal phase has increased, because I am also using in a lot of asynchronous cycles where you are expecting so much more and not getting the number recruited in the first phase itself. Then instead of sending her home and calling her back after 3 months for the next cycle, if I stimulate, and I have found again, my results have been equally competent oocytes in the luteal phase protocol that I have used.
Okay, thank you. So you are doing it routinely in poor responders.
Yes.
Right. It's good to know.
I think, Dr. Rita, you have touched on each and every point in dual stimulation protocol. And I'm so happy to hear your conclusions, actually, because nowadays everybody is propagating dual stimulation, but how much practically it is benefiting us. And, that amalgam of all the studies which you have presented, because all of us are actually experiencing this. And I think you will also agree, we as clinicians are not very comfortable, patient taking gonadotropin and then immediately after 2 days you again take her in cycle. So as you said, very few patients who don't have time and are actually poor responders, and their first cycle, the follicular phase stimulation resulted in much lesser than expected, are the only candidates. Otherwise, I also believe, and apart from oncofertility where we don't have time, but otherwise, these two conventional cycles as compared to dual, I'm also comfortable in that. And I've done a very few dual stimulations, and sometimes it is very surprising that what I expected, even that I'm not getting. And this is a scare in my mind sometimes, that when I'm giving agonist trigger, once in a while we don't get oocytes.
Absolutely.
So, or we get subnormal number of oocytes.
Absolutely.
So that is why I also feel that, counseling your patient, giving her a month break and then taking again into another cycle, this is what I also feel. Maybe Dr. Sujata Kar is there. She has to say something if she has more practical experience on dual, or anybody else. But I am also not a very strong proponent of dual stimulation somehow.
And my congratulations to Anu Agrawal and Dr. Faisi and Dr. Amit for taking this wonderful series, for starting this wonderful series of Catalyst.
Absolutely.
Ma'am, I also have
Congratulations,
one
everyone.
question, ma'am. When I did a dual stim, then in the luteal phase stimulation, most of the follicles went cystic. So I don't know where I went wrong.
So this is
I'm also not very
yeah.
comfortable.
So I will tell you, when you start doing it, you really find it odd because all your hemorrhagic follicles are there, and
Yeah.
it's actually mystical. But when you go through the whole cycle, nearly all of them have cleared up, and there'll be only one or two still, which are hemorrhagic. But when you go through cycle after cycle, you really find them, again like a fresh cycle come up. So of course, this is an experience which comes after you've done a few cycles, but when you start you really find it, how would I do that? I really can't see anything except big hemorrhage everywhere. But seriously, I think it's something to be done to really understand the whole thing.
Dr. Rita, congratulations. And really, it's a wonderfully covered so many studies. But anyway, it's a conclusion was good. It's good for the oncofertility. So what about for the empty follicles? Many times the patient is not educated. She doesn't understand. Then she blame you why you had done double stimulation. And one thing more I wanted to know, like in double stimulation, in your experience, once your first follicular cycle started with ovulation plus gonadotropin, and the luteal phase also is start with the ovulation, or directly when you give the gap, to continue with the gonadotropin, or give again the ovulation.
So, Dr. Tarini, I do both. Of course, and this I'm finding it even more better and better. Use of ovulation along with, especially in poor ovarian reserve, as we said, where you're expecting only 1, 2, or 3 follicles. You're not expecting great wonders. So, in these cycles, adding ovulation plus adding gonadotropins in the second cycle. In the first cycle, ovulation and a little bit of gonadotropin. The second cycle, ovulation plus gonadotropin, all the low dose, 150 to 25 more than enough, and then I take the cycle forward.
And for LS search prevention, you give the antagonist in between.
Yes. I'm very fond of PPOS, so progesterone primed ovarian stimulation. My use of antagonists is very, very little now because I know these are going to be freeze all. I'm not going to do a fresh transfer here. So a PPOS cycle or even an ibuprofen. So I'm doing a study in which we are using ibuprofen as an antagonist, and I've used clomiphene as an antagonist. When you continue for 10 days, you see in that cycle, I never added anything else. So clomiphene itself, we didn't want to add any cetrorelix or any other antagonist. So I think we are growing up with all this. Yes.
Yeah, I was saying you never in between you said whenever you use the antagonist. So that's why I'm asking. So you are using the ibuprofen. So what's the rationale and how the strategy to use the ibuprofen?
So as you know, if you go through the studies, they are using ibuprofen twice a day from day 4, 5, 6, the other way we use our antagonists, and you continue till day 10, and more and more studies are coming up. Although this is not really proven, PPOS has come of age now. You know, there are a lot of centers, and we've done. I think I myself have done at least 200 to 300 cycles of only PPOS. So you know, with nothing, because freeze all has become the routine now. PCOS, egg donors, everywhere we are using only PPOS. But I'm also looking at newer stuff like ibuprofen and clomiphene. So now we are trying, and we are seeing that hopefully our follicles don't rupture. I mean, we keep looking at them, but they are giving good results.
Yeah, so very good idea, very good idea. And it's really new for me. Thank you so much for highlighting this, the use of the ibuprofen.
Thank you.
So congratulations
Thank
for
you
this
so much.
study.
Thank you, Anu. Thank you so much.
you,
Thank you,
ma'am.
Dr. Anu, once again.
And such a nice lecture and with so many take-home messages. So we'll start with the second lecture. Poor responders in low-cost IVF setting. So I would like to invite chairpersons for this session. Dr. Neela Mori.
Hello.
Can you display the CV of Dr. Neela Mori? Mr.
Sure,
Nakul?
Ma'am, do you want to take Madam Santosh Gupta's presentation?
Yes.
She is there now through her mobile phone. So should we go with her, or should we go with the third session?
Dr. Manish, please flash chairperson CVs first.
Okay, sure.
So we'll go fast.
Sure.
Our chairpersons for second session are Dr. Neela Mori. Yes.
Oh.
Yeah. She's chairperson ISAR UP, secretary UP IAGE, and she has organized various national conferences with utmost excellence. Yes. Our next chairperson is Dr. Kanchan Sharma. So we all were interacting with her. She's Secretary Kanpur Obstetric and Gynecological Society, President IHR of Kanpur, and she is ART consultant, laparoscopic and colposcopic. And our next chairperson, Dr. Sunita Arora. She's head of department Infertility and IVF, Bloom IVF Center, Fortis LAFM, Hospital, New Delhi. And she's former faculty member at Government Medical College and Hospital, Chandigarh. Yes. So I welcome Dr. Sunita Arora. And I request Dr. Neela Mori to invite our speaker, Dr. Santosh Gupta. I think she's not here.
There.
Dr. Neela Mori is here.
Just a minute, let me check.
So, Anu, previous chairpersons have introduced me already.
Okay, so you start with your lecture, that will be fine.
Thank you, ISAR, my dear friend, Dr. Anu, to giving me opportunity for talking in front of you. And I apologize for the technical glitch. Although I work in a corporate setup, you have to share my slides, please. Although I work in the corporate setup, but the topic given to me is poor responders in low-cost IVF setting. I think when we think about it, it's more of an attitude rather than science. You keep flipping the slide, please. Next slide. So today what we need to talk is, why should we even discuss when most of us work in a private setup? Why should we even discuss that? So there are certain points which I'm going to raise one by one. So first thing is, WHO definition of health is a state of mind and the physical, mental, and social well-being, not merely the absence of disease or infirmity. So when we know infertility, it causes mental and social well-being, it disturbs. So that means it comes under the category of disease. And 10 to 15% of the reproductive age couples suffers from infertility. It's a huge population Around 80 million couples worldwide are suffering from infertility. It impacts our social and mental health, so it is a disability, and ASRM defines this as a disease. And it is the 5th highest global disability under reproductive age group. So why we need to discuss again? Because it is a basic human right. One right is right to procreate. That means having right to have children of our own, and right to avail treatment for the disease which we are suffering from. So it's a basic human right. So we have to make it available. We have to make it accessible to everyone, and we have to make it affordable. We cannot be catering to the select group of people. Next slide. When we look at world and in the India, there is a lot of disparity between distribution of the manpower, skilled manpower, and availability of service. And we all know infertility does not discriminate between rich and poor. So why we should make it as a treatment only for affordable and rich people? Treatment should not be based on socio-economic status of an individual. Treatment should be accessible and affordable to all. So don't you think it is our moral and constitutional duty to provide treatment even at low cost? The government should provide it. They should develop institute, or they should develop kind of policy where a citizen can take free treatment. If not government, then insurance party at least should become a player and provide infertility treatment. The corporate at least should provide it for its employees, or they can do it as a part of corporate social responsibility programs. And what is our duty as a doctor? I think most of our, we have to inculcate the experience of low cost treatment and design the tool. Right now, our practice is all about giving a lot of drugs, doing an IVF in a private setup, and we don't think and discuss about the cost, and we don't want to discuss about the patients who are not able to afford the treatment. So as a practitioner, we have to design tools and experience so younger generation can believe us and do the low cost treatment. So now the IVF is the new normal in the human reproduction. If we keep on ignoring IVF, like only select few or very rich few will take this treatment, why should I bother? I think we all should think about it as a normal population perspective. And why it is more important to think is, in developed nations like USA, only 24% of demand is met. Unmet demand is still 76%. The ratio is very less in Sweden and Denmark. We all know because of the government policy. India is a developing country. 80% of the patient lives in rural area. More than 90% cannot afford the IVF treatment. Then they are forced to go to subnormal care or not taking any treatment. Private big OPDs in big cities, there is a 40% dropout due to financial reason. We all audit our dropout patient in the end so that we know the reason. Infertility coverage through policies is almost nil. Government institutes are not able to cater to this niche care. So, and when we talk about poor responders, again, the burden is huge. The incidence of poor responders is 5 to 36% of IVF cycle. So it's huge number. It's a huge financial and emotional burden on the patient and family. There is a real shift in the age in opting to start the family. Advanced reproductive age and poor responders in the OPD is a new reality. So we have to understand, we have to optimize, we have to finish in lesser money and fewer cycles. When we talk about poor responders, we only talk about numbers. We never speak about the quality. So why the quality of egg is also important? Because egg is like a mother. The actual volume of embryo until blastocyst expansion is the egg. Protein synthesis, organelle formation, division, membrane structure, transport, everything egg does. Mitotic machinery is the egg machinery. 50% of the nuclear DNA and whole mitochondrial DNA comes from the egg. And as egg become lesser or the age increases, the oocyte mitochondria will reduce. There is a decrease in ATP and there is a disruption of the meiotic spindle. So poor responder, as previous speaker, madam has explained it, that there are 4 categories. today our focus will be on the poor responders, which are expected poor responder. That means group 3, which are young poor responders, and group 4, which are old poor responder. And my focus will be more upon the cost analysis of the treatment and of course the outcome as well. When we talk about the outcome, it is mainly the female age and the number of oocyte, which can predict the live birth. So that's how the age we cannot change. Probably we can change the number of eggs. And then the Poseidon calculator came, and which has given us statistics that when we are younger, we need lesser oocyte to get one euploid blastocyst and to get pregnant. And it is the paradox of life. When we become older, we are poor responder, we have lesser eggs, but we need more eggs to get pregnant. So a 40-year-old will need higher number of eggs than who are less than 35. So always the more is merrier and better, and less is the better lost. It is the truth or it is a propagated lie. I think we have to develop self-consciousness and develop a low-cost setting for the patients and for the generations to come. So now let us dissect the cost of IVF involved. We shall not forget about the pre-treatment and adjuvants, which we simply prescribe. They are of use or no use, but they cost a lot to the patient. If we prescribe them for a month, 2 months, every tablet and every medicine now is a huge cost. Most of the vitamins are 20-30 rupees per tablet. Then stimulation injection, we all know it is a very high cost. Monitoring also cost. Like there was a time when E2LH progesterone was done almost every day. That also cost. OPU and lab cost varies from lab to lab, but then it is sort of an unavoidable cost. Whether we do IVF or ICSI, that is also a cost. Freezing and thawing, it is one variable which cause a huge cost. In most of the low cost setting also, 15 to 20,000 for freezing, another 20,000 for thawing, and maybe in a higher corporate OPD, it could come even higher. When poor responder and advanced maternal age, PGTA and other add-ons, are they required? Because in quest to give them a very high success rate, which whether you do add-ons or not, the very high success rate will not come. Are we doing justice to the patient? And we always forget the cost of travel, visit, stay, food when they come from outside. So minimizing and making the treatment easy also adds to an indirect cost. So if you have to prescribe some kind of adjuvants or pre-treatment, always think of the evidence-based approach. In today's world, 2 of the adjuvants have little proven benefit is CoQ10. It is an antioxidant, essential component of inner mitochondrial membrane, responsible for electron transport in mitochondrial respiratory chain and generation of ATP. With age, there is a reduction in intrafollicular CoQ10. Low CoQ10 is associated with higher aneuploidy. So CoQ10 supplements can give you good outcome in young poor responders. So maybe you can give for a while. And in the old poor responders, it is the DHEA, maybe of some benefit. It is a endogenous adrenal androgens, and it is a precursor of androstenedione and testosterone. And many studies have proven that it increases the ongoing pregnancy rate, live birth rate. But in day-to-day basis, I don't see much improvement with the DHEA, but it is a practice. But at least these 2 adjuvants studies have shown to benefit it. Now, the one basic thing we have to understand in our stimulation protocol is if we give gonadotropin in a supraphysiological doses, it will stimulate only the existing antral follicle. That means to say, if a lady has 5 antral follicle, even if you double or triple the dose of gonadotropin, even you use HMG recombinant or anything, these only 5 follicle will get stimulated. You won't have 15 follicles in a cycle. So follicular rate is proportional to antral follicle count. So that's why the dose of gonadotropin, which is the most flexible cost factor in an IVF setting, the type of gonadotropin, then whether you add antagonist or you skip antagonist, or instead of gonadotropin, can you give them oral ovulogens, or maybe at least do a combined therapy, which will reduce the cost. So one by one we'll discuss. So there are various stimulation protocol for the minimal stimulation. So it is like a mix and match. You can give only oral ovulogens, as madam has spoken earlier, only give clomiphene till the day of trigger, or you can combine it with letrozole. This is only oral ovulogens. And then you can even have oral ovulogens combined with the gonadotropin. You can have only gonadotropin in the lesser doses. So let us say what various studies will say. So these are the ASRM guidelines, which has compared the pregnancy outcome for the poor responder with mild ovarian stimulation versus conventional. And they have given the guideline, and they have compared across all the studies where poor responders were given conventional protocol versus low dose of gonadotropin versus oral ovulogens versus oral ovulogens plus gonadotropin. And they have recommended that in patients who are classified as poor responders pursuing IVF, strong consideration should be given to mild ovarian stimulation protocol due to the lower cost and comparable pregnancy rate in both conventional and mild stimulation protocol. So when we talk about the cost, I think it is our fear where we end up in giving very, very high dose of gonadotropin and increase our cycle cost. This is a very beautiful review and systemic review and meta-analysis by Abha Maheshwari, Geeta Nargund. Geeta Nargund has even established the Mild Stimulation Society. So this study also says, especially in the poor responders, there is no difference in the live birth, ongoing pregnancy rate, and cycle cancellation rate. Although fewer oocytes or embryos were obtained from mild stimulation, however, the number and proportion of high-grade embryos were similar. So there is again enough evidence that why should we increase the cost of the patient by just increasing the gonadotropin dosing. Then this is a series of studies where the conventional gonadotropin was given versus the lesser gonadotropin was given. The number of oocytes were almost similar, and even the pregnancy rates were also similar. So why gonadotropin doses are much more? Because this is the only changeable variable. Maybe your lab cost is fixed, but the gonadotropin doses can change your cost. Next slide, please. Then a lot of us, we speak about the recombinant FSH, recombinant LH. When we talk about poor responder, we say give only recombinant FSH and give recombinant LH only. But this is a study where the urinary gonadotropin, HMG, was given versus the recombinant FSH, and the pregnancy rate, everything was comparable. In fact, there is a insignificant improvement in the HMG group in terms of higher viable embryo rate, live birth rate, and there are various other factors also which were shown better in the HMG group, but statistical significance was not there. So in poor responder, we waste money on recombinant LH and FSH. Probably that is also not required. So this is a pictorial representation of various milder stimulation protocol. All of us are very well versed with that. And we all know about the Cato protocol. And I think from here, the talk about the minimal stimulation and mild stimulation has started. And it is a beautiful design where the clomiphene citrate was given. And from the 7th, 8th day, 150 IU of if urinary HMG was given till the day of gonadotropin trigger. But here it is a Japanese protocol where the oocyte or embryos were frozen. And if you see across the group, there is a considerable number of live births achieved even in the women who were above 35 or 40 years of the age group. So this is again a big RCT where the mild IVF strategy was compared with the conventional IVF protocol. Here, even the cost has been studied. There is a lot of difference between the cost to achieve a pregnancy in a mild stimulation to a conventional long protocol. Please, next slide, please. Next slide, please. Then when we talk about reducing the antagonist, as madam has spoken earlier, there is a one-way PPOS. then we can use clomiphene citrate till the trigger day. We can use even ibuprofen also. Though most of us are familiar with PPOS protocol, it's a beautiful protocol. We get good number of eggs, but always it comes to my mind that from past 20 years, we were even reading the effect of progesterone and estrogen on the eggs and cumulative live birth. Even there were studies where the donor eggs were studied when they were transferred in the frozen embryo transfer cycle, and progesterone exposure has a impact on the live birth rate. And today we are talking about the thing when eggs are exposed to progesterone and we are getting good number of embryos, but that is a topic of debate. But one thing is for sure, that freezing of embryo is a compulsion. Next slide, please. Freezing of embryo is a compulsion here. And if you do the math correctly, next slide, please. In any setup, freezing and thawing is one thing which is very, very expensive. So next slide, please. So if you are looking at saving antagonist, on an average 5 to 6 injections are being used, and if you are using Indian antagonist, somewhere around 7 to 12,000 you end up in saying. But your cost of mandatory freezing and thawing is much, much higher than this cost. And the cost of doing scans when you are calling them in next cycle, more visits, more scans, HRT, then transfer. So it is projected cost is many times higher than what it you save by giving 5 antagonist injection less. Next slide, please. So there are various studies which gives you the cost analysis. Some favor the progesterone, but I think in our clinic we can do our own math and PPOS protocol. If that patient is not a all freeze cycle, we are going to escalate the cost of the cycle. And we all know the poor responders. See, most common cause of our all freeze is when you get higher number of eggs, your E2 and progesterone is higher, then you freeze. You want to avoid the OHSS, and higher E2 and P4 we know will reduce the pregnancy rate. Poor responders are the mild patient who are going to have 3 or 4 follicles. Probably their E2 and progesterone are supposed to be in a normal range. These are the best candidate to a fresh transfer. So why should we increase the cost of our cycle? Then again, this is a case for mild stimulation. So in this, among all intervention of the mild stimulation versus conventional stimulation, live birth rate is almost maintaining equivalent to the conventional protocol, and obviously at a lesser cost. Then there are many add-ons. So when we talk about poor responders, somebody says you use growth hormone, but does it really beneficial? Although there are few studies which will say you add on growth hormone, you will get better eggs. But do you really see that advantage? In my practice, I don't see it. I always believe when you give a simple protocol of HMG or CC, probably that very few follicles and very few eggs you get, they are the one which are going to yield the most healthy embryos. Then the next thing is, are we forced to do ICSI for all in poor responder? When we do ICSI, it costs you a lot of skilled manpower. There's a gadget cost, needle cost, there's a dish cost, and there is a value for time also. You have to hire more and more people.
Sorry to interrupt. You have to conclude your talk because there's one panel and we are short of time.
Okay,
So
okay,
sorry.
no problem.
It's a beautiful talk, but sorry.
In two slides, I'll conclude.
Yeah, sure.
So there is no compulsion that poor responder you have to do ICSI. Probably IVF gives you equally good success rate, and as a whole, you are going to save lot of money. And no need to do freezing in all. It is proven beyond doubt that when there is an advanced maternal age and when there is a lesser eggs, the fresh transfer yields you better clinical outcome, and the time to achieve the pregnancy is also lesser. And monitoring and unnecessary hysteroscopy we should not avoid. We should not forget, when you do a fresh transfer, there is a minimal luteal phase support. Otherwise, in frozen embryo transfers, you end up in giving lot of medicine. And when we talk about low cost setting, PGTA should not be prescribed, and it is proven beyond doubt when there is a lesser when there is a poor ovarian reserve, unnecessary doing PGTA in poor responders, you have to treat 31 extra cycle to avoid one miscarriage. So probably it is not needed. So I would conclude my talk is poor responders and financially poor patient. We have to become patient friendly. For that, we have to invent cost friendly strategies so that we can win over this situation. So we can say proudly that poor responders are, it is just a state of mind and we can win over that. Thank you very much.
Thank you. Thank you very much, Santosh Madam. You have covered all the points very nicely and very properly. In the poor responder, as we know, that usually the treating doctor has a tendency in her mind that we do pooling and we give more and more ovulations. And but thinking these points of yours in mind, we can cut short the cost, of course, using low dose ovulagens, and instead of Antag we can use ibuprofen or clomiphene, as was being discussed, and we should not use ICSI for all, and shifting to routine IVF practice. Very well discussed. Thank you so much. Thank you.
So it was a very nice lecture, Dr. Santosh, and you discussed all aspects of the financial where we can cut short the cost and without compromising the quality. So we can individualize the cycle cost with the we can do individualization without compromising the quality, and without robust evidence we should not use adjuvant. At least growth hormone, they are too costly, and the DHEA and the CoQ, they all are without robust evidence. Just for the sake of some benefit we should not use, and we cut down the cost. And ICSI, if required, then only you can do, otherwise you can cut off this cost. PGTA, yes, we should use in some patient where there are recurrent pregnancy losses, advances more, and we can offer them if they afford it. And thank you. You covered all aspects of your topic, and you discussed a lot in all aspects, every steps, where to cut the cost, where we can individualize our case accordingly.
One question I want to ask Dr. Santosh, just very small, Anu, that are you using only clomiphene and letrose, as you said in a lecture, without using gonadotrophins in an IVF cycle? Are you doing
Madam, no, I don't use, I use mainly CC plus HMG protocol.
Yes, and not
CC plus
letrozole.
low dose HMG protocol.
But not, as you said, somebody in the review of literature, only clomiphene and letrose now.
But personally I have not used. I use CC followed by HMG.
I use
Combination
letrozole
protocol.
plus
Both
gonadotrophins.
combination, yes.
I combine letrozole with gonadotrophins. I prefer that.
Anshu, I've used a lot of clomiphene and letrozole only cycles, and I'm telling you, I have been astounded myself. So I think we should give this a good try, especially like if I had only 2 follicles in the first, then just giving clomiphene and letrozole only.
How do you
without
give,
adding,
how do you give them,
without
Dr.
even
Bakshi?
adding an 150 HMG also. I've got, so, you know, instead of 2, I got 3 follicles. So I think it's something that we can really try.
And ma'am, you go for the fresh transfer in these cases, like letrozole and CC combination?
Yes.
Or you go for freeze-all?
Yes. No, we can do like
But in case of CC and HMG, we can go for fresh transfer also.
How do you give them? Just a little bit. How do you give them? You give clomiphene together with letrozole. What's the protocol?
So in my case, in fact, you know, instead of 25, in practically I use 50 clomiphene from day 2 to day 10, and letrozole 2.5 milligram from day 2 to day 6. So letrozole stops there, clomiphene continues, which acts as an antagonist also, and then a trigger, you know, if the follicle is ready. So normally you because इसमें है ही एक दो, you don't expect any ना, जहाँ पे numbers है ही नहीं. So you want whatever you may give, you will just get 1 or 2 only.
Yeah.
So
interesting.
I think we should give this a very good try, and this is a very good combination to be used.
Both have different mode of action. Yeah.
It's a wonderful discussion is going on, but so sorry. Our panel is waiting, and thanks a lot, our esteemed chairpersons and our speakers, for a wonderful take-home messages and wonderful inputs. Thanks a lot.
Lovely talk, Dr. Santosh.
Thank you, ma'am. Thank you.
Thank you, ma'am. So we are going to start our third session, tips and tricks of ovulation induction in poor responders. And the moderator is our own Dr. Sujata Kar. Kindly share Madam CV, Nakul.
जब तक CV कर ले खाना ले आए बड़ी भूख लग रही है
We all know her. She doesn't need any introduction. She's Vice President at ISAR.
Yeah, I think that's also good enough.
Okay, so over to you, madam.
The panelists.
Hi, Dr. Sujata.
Hi, Tarini. How are you?
उस पे होगा अभी
Anu, invite the panelists.
होता तो इस पे बात नहीं होती
Because I'm not sure who all are there. थोड़ा तो idea दे दो.
Yes, our panelists are Dr. Shaheen Anju.
Shaheen is there.
She's head of the IVF unit of JNMC Medical College AMU.
हो
Dr. Neelam Mishra.
बात नहीं होती ना फिर
Yeah. She's scientific director and senior consultant at Vansh Clinic and Test Tube Baby Center, Lucknow.
No.
Dr. Varda Arora. She's from Lucknow and she's director, senior consultant and IVF specialist at Valencia IVF and Kidney Care Center. Dr. Monica Jindal Singh. We all know her. She's vice president, Bhopal Obs and Gynae Society.
She's
and
also
next,
there.
Dr. Achal Garg. Yes, she's Director, Chief Fertility and IVF Consultant, Colors IVF and Fertility Center, Lucknow. Dr. Sonali Gupta, she's Fertility and IVF Specialist from Patna. And yes, next, Dr. Namrata Reori. She is, at present, she is consultant at New Life Hospital, Varanasi. Dr. Parnika Agrawal. So she's visiting consultant at Apollo Fertility, Varanasi. And she's former assistant professor, Rohilkhand Medical College and Hospital, Bareilly. Over to you, Sujata ma'am. I welcome all the panelists and our moderator.
Okay. So I'll just share my screen. Is it
Hi,
there?
Dr. Sujata. Very good evening.
Good evening. So, as I was mentioning to Anu, in a panel during the webinar, it is, not very easy. So I am not able to see my panelists, but it's okay. We'll try our best. We'll try our best. It'll be a simple discussion on poor responders. And I have just put up 2 cases. We can discuss that and we can each take you all what you feel about it and what is your opinion. Now, we know that IVF success, just a little bit of introduction, IVF success is still related to the number of eggs retrieved. And this is the classical graph that told us that the women who are at this end of the spectrum, who give 1, 2, 3 eggs, they have the lowest possible success rates per cycle. And therefore, for this category of patients, it is how to tailor their stimulation protocol best is the most important thing. And also another problem with poor responders, as we call them commonly, is the lack of a uniform definition for poor ovarian reserve. So that another is a very big issue, because this was one paper which showed that there were 41 different definitions of poor ovarian reserve. But now that we have the Poseidon criteria, and also not many of us regularly use it, I would like to ask my panelists, so what is, just explain to us, Dr. Neelam, you can start. What is DOR and POR, the basic difference between the two? One is a diminished ovarian reserve and the other is poor ovarian response. If you can give us a little idea.
Thank you, ma'am, for giving me this opportunity. Diminished ovarian reserve is when the reserve like AFC and AMH is less. Like in category and poor ovarian response is when AMH and AFC are normal, still we are getting poor ovarian response from the stimulation, our standard stimulation. That is the basic difference.
Yeah. Anyone would like to add anything? Shaheen or Parnika, Varda, I can see you all. Anything to add on these? Are there any other definitions which are creating issues? Or we are good with these?
Madam, in Bologna criteria, they have taken the age is the main constraint for the diminished or poor response.
Yeah,
So
yeah.
in Poseidon, they have divided into 4 groups to
Yes.
overcome
Yes.
this factor.
Yes, yes. No, my question was whether these two are enough for us to deal or whether there is anything else that we should also talk about. Poseidon criteria is, I think, as you said, one of the best possible options that we have now, because it has 4 categories and the top 2 are unexpected poor responders, right?
Yes,
And
yes.
the lower ones are
Expected
poor
responder.
reserve.
So the number of oocytes is also number of oocytes we retrieved.
Yeah, of course. What about the follicle output ratio, the 4th concept? If any one of you can put a
The follicle output ratio is a ratio in which we should measure the oocytes of more than 15 or mm divided by antral follicle count into 100. And it is like if it is less than 33, that suggests poor response. If it is more than 67, it is high response, and normal response is between the 30th to 67th percentile. So it tells you the number of oocyte we retrieved after the during pickup. So
Yes.
another thing is
I
that
think
is follicle oocyte index. That
Yeah.
is that tell you the number of oocyte we retrieved upon antral follicle count.
Yes, actual oocytes that you got. So
Yeah,
anyway,
yeah.
the point, the concept here is, see, this patient has a good ovarian reserve, but poor ovarian response. That could be, of course, because of many reasons. One of the reasons being suboptimal stimulation protocol. This patient has a poor ovarian reserve, but her ovarian response is very good. So this is just a concept to have. And in any case, the diminished ovarian reserve is a very difficult group of patients, as we all understand. The previous 2 speakers also in their lecture have covered a lot of possibilities that one can manage to. But just to, give a overall idea, number 1, how to manage them is to identify patients who are at risk and then to individualize the controlled ovarian stimulation. That is the most important thing. And then, of course, lab procedures, embryo transfer tailoring, all that. We are not going to go into that. I thought I'll just discuss 2 cases quickly with you all. So this first one is a case of Poseidon group 3. She is a 33-year-old woman. She is married for 9 years. She's trying to conceive for 8 years. Her basic tests are normal. Male factor, tubal factors appear to be normal. In the past 7 years, she has undergone from various places. She has undergone ovulation, induction, timed intercourse, IUI, etc., etc. She is a normal BMI, about 23. And on her examination, she's ultrasound is almost normal, except that she has a low antral follicle count, which is 2 and 3. This is the report that she comes to me. Now, when we at the IVF center do the baseline hormones, this is her hormonal profile. She's only 33. And for 7 years, she's been running from pillar to post. Nobody has advised her any advanced treatment. They've only been doing ovulation induction and IUIs. So her FSH is 15, LH 7.8, E2, P4. AMH is only 0.12. Others appear to be okay. Now, question number 1 is how it was certainly not correct to treat this patient at level 1 centers for so long before evaluating her ovarian reserve. So my question here is, these days you will notice that even in periphery, even in smaller centers, even in the PSCs, normal blood tests would not have been done, but at least a AMH would have been done. So, is there a guideline as to when we should evaluate an ovarian reserve? Because see, normally when I am also practicing in an IVF center for 30 years, but I will not do an AMH for Tom, Dick and Harry. I will do a AMH when I am taking her up for IVF, or if I am suspecting a poor response by ultrasound or something like that. You would like to say something about when ovarian reserve should be done for women, or should you want to do it for anybody, even a 25-year-old?
So, ma'am, when we are going for an infertility treatment and we do the first scan, I think there we are doing an ovarian reserve testing because we are seeing the antral follicular count. So that is one thing that all of us are doing as infertility specialists. As per the AMH and as per clinicians who are at level 1 centers who are not doing their own scans, if the patient is already trying for a year or more and she has not responded to any of the standard or oral ovulogens or anything, then we must go for a lab testing for those patients.
The ovarian reserve testing.
Right. The ovarian.
Yeah. So my
One more thing
was,
is, ma'am, you're absolutely right about serum AMH, because many a times we see that the findings are very erroneous. And
Very
labeling a
erroneous.
female with a poor ovarian reserve just on the basis of one report is, I think, quite unjustified.
Yes.
So this is what usually happens when the patient comes to us like she's in a state of anxiety just on basis of, and then we scan her and her AFC is quite well.
So I would say that you all feel that there is no need for doing a ovarian reserve testing very early, because the ultrasound is going to give us a lot of information.
Yes.
Right? That should be good enough.
Lata ma'am, I wanted to ask one doubt.
Yeah, Monica.
Monica here. Madam, you have labeled this patient as Poseidon 3. Expected young poor responder. So she has not had any previous IVF cycle.
No IVF cycles. For 7 years, she was roaming around.
AFC and AMH is low. So,
but
AMH criteria, by that it is
still,
low.
I think Poseidon 3 requires one at least bad cycle.
No,
If
that
I-
is
that is 1 and 2.
1 and 2.
That is 1 and 2.
That is 1 and 2.
Achha, now let's get back to this patient. Now that you know this is her criteria, what is your advice? Would you like to go away straight for donor oocyte?
No, ma'am.
In this, because she's a
Anyone
young
saying
particular
yes?
patient.
She's a young
Any one
patient.
of
we should- she's a-
our panelists saying yes?
No.
Ma'am,
I will directly go for
a
IVF.
detailed counseling is needed in this particular case, and we have to see the financial condition of the patient as well, because sometimes we have to explain that there might be chances that when the stimulation is done, we might not get any oocyte, or there are chances that we even if we get the oocyte, there won't be any oocyte embryo formation in such case.
So Namrata has taken the easy way out by saying that she will give the,
No, ma'am. I will counsel the patient and I will tell you go for the stimulation, but I'll also tell the cons that sometimes there are chances that you won't get any oocyte, like you won't. Sometimes the embryo won't be formed because, ma'am, in Varanasi, in our setup, we get all sorts of patients, and sometimes they just say to us, ma'am, why you did not tell me this thing that we won't get any embryos? I would not have opted for this treatment. So, ma'am, it's a very case-based scenario. We have to counsel.
Actually, this is a
AMH.
Ma'am, may I add
Also, it is an
something?
unexplained infertility, so her success rate might be low, ma'am. Because that's an unexplained infertility. They have been married for 8 years, 7 years of ovulations and everything. One IUI has been given. So sometimes what we see that genetically they're not compatible. So Namrata is right in saying that we have to counsel her for both the things. But it's last wish is hers. But we have to tell her the cost is going to be.
But I just want to bring to your notice here. I mean, correct me if I'm wrong.
And FSH is also 15.
15.7.
Even though if
there
it
are
is
chances
15,
that,
I think she's just 33 years. We should give a try. And in some, like I am working in medical college, even 0.3, 0.03, I am giving a try because
so that
most
is
of
what
our
I wanted
patient,
to. That's what I wanted to bring to your notice, that AMH is not an indicator of pregnancy or not, of success. It is an indicator of how much ovarian reserve is left. If she's young, even one oocyte can give you a pregnant. I mean,
yeah, it's a 4
technically,
oocytes which is needed for
but this
one
is a
nucleotide
difficult
of-
question. This is a difficult question.
33-year-old female usually, what we have seen is not very receptive about the donor plan.
Yeah.
So my decision would be more dependent on her financial ability. If she is ready to shell out
now,
money,
Namrata,
then I think we'll give her a fair chance of induction using
absolutely.
recombinant
So,
FSH
Namrata, now you are in
and
trouble
LH.
because the patient insists on using her own eggs.
Yeah.
She does not want oocyte donation under any circumstances, and then she decides to take up IVF. Now, my question to each one of you quickly, just the protocol. What stimulation protocol would you use in this patient? Quickly. Varada, what would you use? Antagonist?
Ma'am, I think I would give her some kind of a pre-treatment, some CoQ4.
No, that's done.
For at
That's
least
done. Yes, you give her
6
some.
weeks.
Yes.
And then followed by,
or maybe
I'll
you'll
go for
give
an anti
DHEA also.
protocol.
DHEA also.
So
yeah, DHEA
I will give
and
some
CoQ4 I will
pre-treatment
give
as
her.
well.
And then I will do the routine investigations, everything which you've done.
Yeah,
and,
that is done. What about the
and
protocol?
routine hemogram, everything. And then I think I'll go straight away with an antac protocol, starting with a good dose of recombinant FSH, around 300 IU. And
So you would go with a regular antac protocol.
Madam,
yeah, I'll go with an antac protocol. Another option which we have in this case is a mild stimulation protocol followed by fresh transfer, or an antac protocol with a freeze option.
Okay.
And we have to see at her
Anybody would like to say something else?
Ma'am, I like to see her
an
AFC.
antac protocol with a dual trigger also.
Dual trigger. Yes, that's a good point.
Yeah.
Neelam, Dr. Neelam?
Ma'am, I'll see her AFC. What is the pool like? If the
AFC was
pool
2
is
and 2.
2 and ma'am, like in uska size difference is, what is the size difference? Like if one is very big and 2 are very small, so we have to
You'll
synchronize
the cycle
synchronize the cycle to get a better
or
outcome.
How will you synchronize?
Ma'am, I give agonist cycles in poor responders.
Okay,
So
that's
I would
also
like
dose
to
of,
give, and I use HMG
yes,
right
and
from the
I think
beginning.
Neelam, you're absolutely right. Slowly, even people have started understanding that even poor, because there was a time when we used to think poor responder, no chance of agonist.
Yeah.
Because, it's going to down regulate, you'll need a higher dose, you'll get less oocytes. But yes, that is changing. You can do the, short
And
protocol.
luteal phase, we can do luteal phase start and then.
Luteal phase progesterone, luteal phase estrogen can be given.
Ma'am, estrogen doesn't work in my
Pre-treatment
hand. It
doses
doesn't work,
also
ma'am.
can be done. For
Okay.
I think
What about
estrogen,
the
we
androgens?
should start
What
with
about
the
the
estrogen.
androgens and AECP regimen, in which you give the androgens and you give the estrogens, and then you start with the antagonist?
Actually, the transport trial, there is no evidence of giving androgens. It is not very much
Young
effective.
patient, no,
And
androgen I
we
do.
should not wait, I think, waste the time of 3 months, like for DHEA, or 60 days for testosterone gel, or 21 days. I think we should take her for stimulation, and we should just to synchronize. Either we should go for long agonist protocol, or we should go for estrogen primed antac protocol.
And sometimes CC given in previous
CC
cycle for
with
12 to 18 days also works very good.
Progesterone
Like, don't give her for 21 days with just short 12 or 15 days of CC. Will synchronize her oocytes and then start stimulation. I do, ma'am, LH on the day 2, LH and E2. So if it is very low, we start HMG right from the beginning. If it is proper, we give Rec
You
FSH.
don't do an
and then-
FSH on day 2, no?
Yeah.
Do you
LH
do
and
FSH?
LH.
No, not required, ma'am.
Not
E2
required.
you don't.
Actually, I am working in medical college, and we are not doing any lab tests like estrogen and progesterone, and we are getting I think almost
No, this
similar
particular
results.
patient.
Madam,
If you don't find at least good follicles on day 7 of the cycle, then you can add LH. So this is one of the recommendation which I had seen.
Yeah, but adding
going in
LH,
for
we
a
usually give
LH
HMG,
is
so
very
that's
costly.
No, don't
it's-
add
No, not LH.
LH
HMG
like
can
that.
be added.
Nobody is adding.
Yep.
I think the adding HMG would be more than
HMG
enough
is, yeah.
to add for. So anyway, I think you people have covered almost all. agonist, antagonist, natural cycle, minimal stimulation, all these are options. Adjuvants, I think most of us would like to go in for DHEA and CoQs and all that, at least for some. But then, yes, absolutely, the evidence is not there supporting any one of them other than growth hormone. I personally have never used growth hormone. It's pretty expensive, not available in my side, and we don't use it so much. Any one of you have any experience with growth hormone?
Yes,
Ma'am, when yes, ma'am,
I
when I
use
was
growth
working with Dr.
hormone.
Rita Bakshi, ma'am, we used to use a lot of growth hormone in these poor responder patients. And
Okay.
yes, so ma'am, it has worked wonders.
Yeah,
But
yeah.
we could only use it for patients who could afford it.
No, it doesn't do any wonders, madam. It doesn't do any wonders. The only thing is growth hormone is given to those patients who can afford it. And nowadays there's a brand which is affordable.
Yeah.
Now,
So I just said that is one option which the evidence, I mean, the literature, if you actually look at it, shows that it might help. Others don't have much support, but I think most of us will give DHEA for a couple of months. But again, DHEA has to be given for at least 3-4 months for it to have any kind of benefit, if at all. If at all. But you know, earlier we used to use a lot of microdose flare. I used to use a lot of micro. Now, of course, everything has become antagonist, but I used to use a lot of microdose, ultra short protocols, short agonist protocols. All these were also used quite a bit, you know. Agonist you give and then you stop it when they get periods, and then you use antagonist 2-3 doses also. Those combinations are also used. It is done a lot. So anyway, what I did, this is an old case. So what we normally I did used to do a lot of short protocols that time. I don't know whether you people use it these days or not. In the first cycle, she gave only one M2, and that was a grade 2, grade B 8-cell embryo, and she was not pregnant. Now, problem with this patient is that she has a high day 2 FSH and low AMH. So is there anything that you would like to suggest to, like one of you said about down regulating? Is there any other choice? Because this was an old case at that time. What actually I have done it, let me tell you. So what we had given was OC pills to get her periods, and whichever cycle the FSH or the antral follicles were good, at least 3 or 4. Those are the cycles that was targeted.
That can be used. That strategy is good, madam. You use
So you know, I don't rely on FSH these days anymore. But for the poor responders, we also know the antral follicle count can vary from different cycles to different cycles.
There are waves of folliculogenesis actually.
Yeah. So supposing one cycle, when I see it's really bad, 1 or 2 only I can see, I sometimes wait. Let's see the next cycle, maybe you will have more antral follicles. And then if you get 3 or 4, maybe you'll find 4 or 5 the next cycle. So 3 or 4 the next cycle. So, you know, this is also a good strategy that you can target day 2, the months in which she has better antral follicles. And in the second cycle, I think, no, multiple times we had to give her wait and then do for her. But in the second cycle with an ICSI antagonist and letrozole. So this was a letrozole and FSH cycle, and she did get pregnant. She again got 4 M2s, 3 fertilized and cleaved. On day 3, embryo transfer was done of a 12 grade 1 embryo. There were 3 or 4 embryos and 2 embryo transfers were done. She was pregnant and delivered. So this was
how do you use the letrozole? Because sometimes I've seen I use the letrozole and it selects the follicles. The only 1 or 2 start growing very fast out of the cohort because of the high dose of letrozole. It suddenly leads to a spurt of 1 or 2 follicles. The rest of them don't keep up. So means what is your dose of letrozole?
When you combine it,
yes, ma'am.
How do you this thing with gonadotrophins? Usually, you will get.
What is the dose? You use 5 mg/OD or 7.5 mg/OD or
no, 5 milligrams.
And we start HMG from the start with letrozole.
Yeah.
Yeah.
You can scatter also, ma'am. You can start HMG a little late also.
You can.
You can.
But you can. And usually I give a androgen gel 15 days before her expected period. So I think we've covered all this. We've testosterone gel, DHEA, recombinant LH. So I think we can skip all this. And then This was another one which we had discussed, estradiol in luteal phase, but many of you did not like this protocol, right?
No, madam, there is
But
one.
with antagonist, it works.
This is something which is very good because this also
I'm using
It is good with
it
antagonist.
synchronizes the follicles. Dr.
Yeah, it's
Neelam, I
around
think,
you
said
give
that she
4
likes to do that.
milligrams, 4 milligrams for 5 days. It can
And
really help
also,
produce
you
a good
know,
cohort.
Day 21.
also to give antagonist.
Yes,
Yeah. Just
2 days and 3.
menses.
Yes.
3 menses you can give. You can also give post menses day 1, day 2, day 3.
Day 3, yeah.
So these are various strategies in which we can get a coordinated cohort of whatever follicles are there. So this is the one which I was talking about. Agonist, antagonist, conversion protocol. This is supposed to be, there are quite a few colleagues that I know who like to do this. So oral pill you give, and then you start an agonist like the usual way we used to start, then stop it when they get their cycle, then start with FSH, and then add a HMG also later, and antagonist when required. So this is also conversion protocol. In this protocol, estrogen is given for a couple of days just before her expected cycle. Acha, now one more case I have. Quickly we can discuss.
We will continue with the antag.
Pardon me?
Would you like to continue with the antag? Like in this, you have shown that slide. This antagonist is started on the day 2 of the cycle.
Yeah.
Before FSH. And
Before
it is
FSH.
continued. It is.
It's at a, yeah. I don't use this protocol. This is just, I have taken it from somewhere. But antagonist, you can add any type.
Like in this protocol, I think they have continued. They have yes. So
they have continued.
So I think the dose of gonadotropin will
be very high.
Yeah.
Will be very high.
Ma'am, in all agonist protocol, the dose of gonadotropin really goes very high. You use agonist and your requirement almost increases 30%, 30-40%.
That I'm not sure, but even I don't
agree.
Get that feeling too much.
Yeah, I have always.
So I think let us, we barely have 5-10 minutes more. So this is the latest kid in the block, which everybody is, you know, wanting to do this. So I thought I will just put this as a last question and a little bit of discussion on this issue. So this is a Poseidon grade 4. So she is 42 years old. And she has very low AMH, 0.4, FSH is 9.8. And our antral follicles are just about 3 in both the ovaries, 1+2. So she's a real with very diminished ovarian reserve. Now, in this kind of patient, is there what do you think about PRP, stem cell, etc., etc.? Ovarian rejuvenation. What is going on? You know, so much these days. Tell us something about your personal experience.
PRP does work in better in Poseidon 3, not in 4. Actually, in 4, it is all the aneuploidy rate is much higher. So.
Multiple cycles of stimulation is better.
I think pooling of the oocytes is better than using
of embryos are
PRP.
Madam, there is no
Yeah, you can go in for a duostem, or you can go in for a donor.
But everybody is advising PRP and doing it.
So I think it's Poseidon 3 group.
I'm just saying, that's what the practice is going on so much.
Actually, I'm doing, and it's doing good with the Poseidon 3 group, not in in 2 group 2.
In my personal experience also, PRP seems to be working well in the endometrium. But it doesn't seem to be working much in the...
PRP has a limited role in endometrium also, only in Asherman's cases, and thin endometrium due to Asherman syndrome, it really has a remarkable effect.
Yeah,
otherwise, not in all the cases.
We have not published anything, neither have I kept any data which I can quote here. What I'm saying,
but I have not done much cases. Two cases with the PRP they conceived, but one aborted, one continued. So I can't say it's just because of PRP. It may be because of just second stimulation.
Yeah, because
how do you inject it? You inject it in the cortex?
Yeah, in the cortex and by laparoscopy as well as ultrasound. both ways.
Laparoscopy, I feel, is much more sensible because vaginal, somehow sometimes there is bad experience with
Actually,
about
I'm also doing, if we are getting,
infection and ovarian abscess
ma'am,
and all that.
I'm also doing with the stimulated cycle. If it is unexpected hyporesponder, we are doing the PRP in that case. With the
In the same
retrieval,
cycle?
after
In the same cycle you are doing?
after retrieving the oocytes, I just inject the PRP. And if she wants to go for second cycle, we
Even
can.
I do this.
Okay.
Even I do this because you're already doing a egg collection.
Yes.
And you are seeing that she has very low number of follicles and all that. So I do advise this, yes, once in a while. I don't have too much experience with, I mean, I don't believe in it too much, so I haven't been using it too much either, advising my patients. But yes, during egg collection,
Current guidelines, the current guidelines which IFS has brought out with the European Shesh Sunkara and the group, they have completely refuted the use of PRP and both
that's what I said.
It's a strict no, like category A recommendation.
Yeah, that's because listen, they will base their recommendations on evidence. Whatever evidence is there.
Actually,
We all
all the-
agree that evidence is not there. But then also we have to understand who will create the evidence. You have to do the cases to create evidence, no? So that is why currently it should be done only in the purview of a research trial. Anybody who's using PRP.
Ma'am, growth hormone also, the same group studied growth hormone. They came to the conclusion that it's not a strict no. There is a particular group of researchers who can benefit from growth hormone. Similarly, microdose flare, they have said. If you are expert at microdose flare, you should keep using microdose flare.
I used to love microdose flare.
Stop agonist protocol. Again, Ashra is
But
saying.
now antagonist has become so much easier.
Yeah.
And you feel ki jada, it's not too much difference, so you end up using that.
Yes.
So duostim, I think the speakers have talked, isn't it?
Yeah.
So I don't think, and I also feel that going to be 9 o'clock, so we have to wind up. What about your experience with duostim?
No.
No? Monica?
Madam, I used it in one of my patients. She had just now non-Hodgkin's lymphoma, young patient going to get married. So I used duostim for her. But just now we heard the talk also. Sometimes in a duostim, what happens is the remaining cohort of follicles, the hemorrhagic follicles are also there. And fresh follicles are also there. So your confidence level is low. So unless you're doing a lot of duostim, suppose like you should be doing minimum 3-4 cycles in a month in order to get that confidence of 20 cycles in 6 months. And then you will come to a conclusion. The ones we are doing are very few and very random, madam.
So, I mean, what you're saying is that you use it once in a while, but you are not convinced. I mean, you're not sure whether it's a good strategy or not.
A lot of duostim I have used, not duostim, the dual trigger.
Duostim is the same, almost the same as oocyte pooling. I mean, oocyte pooling, embryo pooling and all.
Only it saves time. It saves time because
it saves time, and it has scientific basis also, because like you said, there are multiple waves of folliculogenesis during one cycle, and that is the
time is very important in fertility patients. I had this
that is the logic.
But madam, her chemo was due, and I had to set her free before that second cycle of chemo. We overshot by 2 days because retrieval and everything. So anyhow, she got the chemo and she had lost her hair and all that. So we wanted to be very fast. And now she's going to get married and all. The sites are frozen with us. So it's very important, madam. You should know which treatment to individualize for which patient.
Yes, absolutely. Because ultimately it is individualizing. And I think all protocols, and I think like what one of you said about the fact that whatever you are most comfortable with and whatever you've used maximum is, if that gives you good results, I think that also is a good enough, protocol to use, apart from as time goes by, evidence collects. I think one of the double stimulation, double trigger is an excellent strategies to increase M2 oocytes. So those things certainly we should include in our armamentarium. But otherwise,
One thing, ma'am, I just want to say about duostom, that earlier when we were doing duostom without the break thing, so that we wouldn't get good results. But then when we started giving that 4 days break with meprate or progesterone, then I think the cycles improved, the cohort, the yield improved in the luteal phase. So
you
I
give a
think
break
you're
of
doing
4
that
days,
thing.
is it?
That 4-day break, you think, ma'am?
You
Earlier
can
when you used to just continue the stimulation.
No, you after giving the trigger and doing the pickup after 3 days or so, 2 or 3 days again start stimulation. That is what we do.
The break should be less than 4 days. The
Yeah.
gap should be less than 4 to 5
Yeah,
days.
yeah. So I guess we are at the end of our discussion. It's always a little difficult to do a panel on the, in a webinar. So I hope Anu is happy with whatever we discussed. Anu, thank you very much. Thank you very much
It
for
was
this
a
opportunity.
wonderful session.
This is a wonderful panel
Thank you,
discussion, madam.
thank
I was hearing, and
Yeah.
everybody gave their best inputs.
Yeah,
Great discussions.
So these are the patients
Congratulations to
now we
you and
normally
Anu
encounter
and
in our
all.
OPD.
Yeah. So, thank you so much, dear panelists.
Thank you, ma'am. Thank you, Dr.
Thank you very much.
It's wonderful.
Thank you, Dr. Anu. Thank you, Kanchan ma'am.
Thank you, Anu ma'am.
Thank you, ma'am.
Thank you.
Dr. Anu.
Arni ma'am, good night, ma'am.
Thank you.
Thank you, Anu ma'am. Thank you for
Bye-bye. Good night.
Thanks a lot. Dr. Manish, are
Thanks,
you there?
Thanks.
Yeah, ma'am, I'm there. If okay, can I give a thank you note if that's okay, ma'am?
Sure.
Sure. So I would like to, on behalf of Universal NutriScience, to express our sincere and heartfelt thank you to our President of ISAR, Dr. Amit Patki sir, for guiding us and making this vision and the webinar a great success. To our Secretary, Dr. Asha Bakshi ma'am, and obviously Dr. Anu Agarwal, who has been a fabulous convener along with Dr. Festy Lewis in helping us with this webinar. Speaker Dr. Santosh Gupta, Chairperson Dr. Anshu Jindal, Dr. Taneja, Dr. Dagar, Dr. Rita Bakshi, Dr. Neelam Ori, Dr. Kanchan Sharma, Dr. Sunita Arora for their wisdom and direction. Dr. Sujata Kar for steering the course with grace, panelists Dr. Shaheen Anjum, Dr. Neelam Mishra, Dr. Arora, Dr. Achal Garg, and also Dr. Sonali Gupta and Dr. Namrata and Dr. Pranika Agarwal for their invaluable contribution. And also would like to express sincere thanks to every participant. We had more than 100 and nearly 500 logins for this webinar, and every contributor, including our UNS members, that is Vikas, who has worked tirelessly behind the screen, helping the speakers also, and also Nakul, who has been working hard, and the entire UNS team. Thank you for all your efforts, your time, and your care. Together, we have advanced in a way. With gratitude, we cherish every moment and insight. So again, a warm thank you from UNS, and thank you, and looking forward to our next webinar, which is a monthly webinar, same day of the month. Yeah.
Thank you, NutriScience.
Thank you.
Thank you.
Thank you so much.
Thank
you,
Anu.
Anu.
Thank you, Anu, and everyone. Good night. Was
Good
a
night.
wonderful
Thank you.
panel
Good night,
and
everyone.
program.
Thank you very
Invaluable.
much. Thank you, everyone.
Thank you.
Bye.
Bye-bye.
Bye-bye.
And thank you to our technical host also, the webinar host team also. Thank you.
Thank you.
Thank you,
Thank you.
Nutri Sciences, and congratulations, Dr. Sujata Kar, our Vice President. It was
Yeah,
wonderful moderation.
I request Dr. Nirav, please no, stop the recording.
Recording stopped.
Dr. Anu ma'am, thanks a lot for all your support and help. It's been a tireless effort from your end, ma'am.